Now we'll move on to non-Hodgkin's lymphoma. So non-Hodgkin's lymphoma can either be a B cell type of non-Hodgkin's lymphoma or a T cell type of lymphoma. Under B cell type, we are going to have various lymphomas depending upon the site of the B cell from which it arises. So in the lymph node, we have the cortex, paracortex. In the cortex, we are going to have the lymphoid follicles and the paracortex, right? So lymphoid follicles is the origin of B cells, while paracortex is the site of origin of T cells. And then we have the medulla, wherein you have the plasma cells and all. While in the follicles, you are going to have a germinal center. Then you are going to have a surrounding region, which is the mantle zone. Then furthermore, we are going to have the marginal zone. So each of these sites can develop into lymphomas. Based on the specific site, they can develop into lymphomas. So lymphomas arising from the marginal zone are going to be called as marginal zone lymphoma. Lymphomas from mantle zone is going to be called as mantle cell lymphoma. Lymphomas from the germinal center are going to be many subtypes like follicular lymphoma, DLBCL, Burkitt's lymphoma. All of these are going to arise from the germinal center. Even Hodgkin's was arising from the germinal center B cell, right? Then you are going to have something called as a hairy cell leukemia as well. Okay, so rest of it were all called as lymphomas, while this is a hairy cell leukemia because it is going to involve the peripheral blood. Okay, so apart from this, we had already seen about small cell lymphoma, which was the counterpart of CLL. So CLL was in peripheral blood, but SLL, the small cell lymphoma, was in lymph nodes. So that we had already seen. Okay. So I'm not going to discuss it again here. So under T cell lymphomas, we have many lymphomas again, but we'll discuss only the major ones, which is mycosis fungoides, which is a cutaneous T cell lymphoma, and then anaplastic large cell lymphoma, ALCL. Okay. So first we'll start with the T cell lymphoma, which is anaplastic large cell lymphoma. So ALCL is a large T cell lymphoma, and as the name suggests, they are going to be large cells. And they are going to classically have ALK rearrangements. So anaplastic large cell lymphoma, even in neoplasia we had studied, right? So ALK rearrangements are going, ALK kind of mutations are going to be seen in ALCL, neuroblastomas, and lung adenocarcinomas as well. So ALK rearrangements is going to be seen in chromosome 2p. ALK location is in chromosome 2p. Even in Hodgkin's lymphoma, we had chromosome 2p gain, right, which led to the NF-kappa B activation. So ALK location is also chromosome 2p. So this is going to usually affect the young adults, so adolescent age group and the children. And then microscopically, if you see, it is going to have two classical features. First one is going to be called as the hallmark cells. The hallmark cells are cells which have a nucleus which is having an embryoid kind of a nucleus, as if an embryo is sitting. So a folded kind of an embryo kind of a nucleus is going to be there. Embryoid nucleus or a horseshoe shaped nucleus. Then we also have another feature called as a donut nucleus. So embryoid nucleus is, if this is the cell, the nucleus is going to appear as if it is having an embryo which is folded. So same like it appears like a horseshoe as well, right? So it is called as a horseshoe kind of nucleus also. Donut nucleus is when it is going to have a nucleus like this, and in the center you're going to have a hole like this. Okay. So this is the classical image of a ALCL. In this cell, if you are seeing, it kind of appears like a donut, right? So this is the nucleus, and center you are going to have a hole like this. And look at these cells, they are going to have a folded embryoid kind of a nucleus. All of these cells are having very bizarre kind of a nucleus. So this is the classical findings which we see in ALCL. And the IHC, immunohistochemistry for ALCL, is again going to be classic. Here it is going to be CD30 positive. So CD30 is positive both in ALCL and also in Hodgkin's lymphoma, the classical type. And apart from that, it is also going to be positive for ALK. So ALK rearrangements, if it is going to be present, you can put the ALK IHC, which will come positive. So coming to mycosis fungoides, which is again a T cell lymphoma, which is actually involving the CD4 positive T cells, arising from the CD4 positive T cells, and it is a cutaneous T cell lymphoma. So we have 3 stages of development of this lymphoma. So I'm not going into the details there. So it is a cutaneous T cell lymphoma, and any T cell lymphoma involving the skin will show a feature called as epidermotropism. So meaning from the dermis, these lymphomas, they have a tendency to move towards the epidermis and involve the epidermis. So epidermotropism means liking. So epidermotropism is going to be there. So as it moves into the epidermis, it is going to form some abscess in the epidermis, which is going to be called as the Potrier's microabscess. So these Potrier's microabscess are nothing but collections of these atypical lymphoma cells, which is forming an abscess kind of thing inside the epidermis only. So in this, if you see, these two are small abscesses which are composed of these atypical lymphocytes. So lymphocytes are normally not supposed to be present in the epidermis, right? So in this condition, you are going to see this Potrier's microabscess composed of this lymphocytes. So don't confuse it with the Munro's abscess. Munro's abscess was composed of neutrophils, and you are going to see that in psoriasis. So same epidermal location, if you have a collection of neutrophils forming an abscess, that is going to be called as the Munro's microabscess seen in psoriasis. So it is different from Potrier's microabscess seen in mycosis fungoides. Okay, so this microscopically, if you see, you are going to see neoplastic T cells, which are going to have the characteristic immunophenotype. So from the dermis, it is going to involve into the epidermis. So in this image, if you see again, so here lots and lots of lymphocytes are there involving the dermis, and from here many of it had invaded into the epidermis, and it has formed this Potrier's microabscess. Apart from that, if you see this cell here, so this cell here, this cell here, and this cell. So all of these cells are becoming quite atypical, right? They are having this kind of a nucleus. So this is called as a cerebriform nucleus. So they are having a folded nuclei basically. So infoldings of the nuclear membrane is going to be there. So it is appearing as if it is looking like the brain. So it is called as cerebriform nucleus. So the cerebriform nucleus is again characteristic for this mycosis fungoides. Okay, so in peripheral blood also this mycosis fungoides can involve. So in mycosis fungoides, if it is involving the peripheral blood, we are going to call it as Sézary syndrome. And then Sézary syndrome, again you are going to have this T cells which have this cerebriform nucleus, and these cells are going to be called as Sézary cells. So this is the image of the Sézary cells in the peripheral blood. So if you see, this is the lymphocyte which is atypical. So compared to the normal RBC, look at its size, it's quite big. And then look at the nucleus, it is all having multiple infoldings like this, as if it is a brain kind of sulci and gyri present. So these are called as Sézary cells. So now we had seen about T cell non-Hodgkin lymphoma. Let's move on to the B cell lymphoma, starting with marginal zone lymphoma. So marginal zone lymphomas are usually, they can arise both in the nodal location and also extranodal locations. So extranodal locations, it can happen in the MALT tissue. So MALT is mucosa associated lymphoid tissue. So these are nothing but the lymphoid tissue present in the GIT usually. So the when it occurs in those GI kind of MALT tissue, it is going to be given the name of maltomas. So maltomas are nothing but extranodal marginal zone lymphomas only. And it is the this maltoma is going to be most commonly maltomas are seen in the stomach. Okay, but remember, the most common lymphoma in the stomach is going to be DLBCL only, but maltomas usually most commonly affect the stomach in an extranodal location here. Okay, and any chronic inflammation I mentioned can turn into lymphoma. So this the type of lymphoma which is going to happen in a chronic inflammatory background is a marginal zone lymphoma. So examples will be H. pylori associated lymphoma, right? So stomach maltoma we saw. So that is going to be H. pylori associated. So H. pylori is going to cause chronic gastritis, wherein you are going to have lots of chronic inflammation. So in that background, it can develop into a lymphoma, which is a marginal zone lymphoma. Apart from that, even in Hashimoto's thyroiditis. So Hashimoto's thyroiditis and then Sjogren's syndrome. So both of these conditions are autoimmune conditions. So any autoimmune conditions, obviously chronic inflammation is a part of it. So these are again going to be prone for developing marginal zone lymphomas at that site. So in thyroid, you can get marginal zone lymphoma. And then in salivary gland or lacrimal gland as well, you can get a marginal zone lymphoma. Okay, so the best thing about this is, since it is associated with chronic inflammation, if you regress the chronic inflammation, it is control the chronic inflammation to certain point of time, this lymphoma can regress. Okay, and the classical genetics associated with marginal zone lymphoma is going to be many translocations. So in B cell lymphomas, you'll be reading many translocations. You need to remember each one of them. Okay, so the most common one here will be the translocation 11-18. Apart from that, you can also have translocation 14-18 and translocation 1 and 14. So this translocation 14-18 is also seen in follicular lymphoma. Okay, so just remember translocation 11-18 for marginal zone lymphoma, and this translocation 11-18 is going to be associated with chemo resistance. Okay, so whenever this 11-18 translocation is there, it is going to have some chemo resistance. Then the next type of B-cell lymphoma is the mantle cell lymphoma arising from the mantle zone, which is composed of the naive B cells. So usually the patients are around an elderly age group, so 50 plus age group will be there, and they'll present with lymphadenopathy here. And if they involve the intestine, colon, so there you are going to have a specific finding called as lymphomatoid polyposis. So if you see the gross examination, it is going to have multiple polyps on the mucosal aspect. It is because of the infiltration of the lymphoma cells into the mucosa, lamina propria. It is going to be filled up with this lymphoma cells, so that is going to give the appearance of a polyp. And okay, so this part is called as the lymphomatoid polyposis, which is going to be seen in this mantle cell lymphoma. So the genetics involved in mantle cell lymphoma here would be the translocation involved is translocation 1114. So 1118 was marginal zone, 1114 is going to be mantle zone lymphoma. So the immunophenotype and the IHC for this mantle cell lymphoma is going to be characteristic again. So when we were reading SLL, I mentioned something, right? So this is going to be CD5 positive and CD23 negative. So CD5 positive, 23 negative, both were positive in SLL, while only CD5 is going to be positive in mantle cell lymphoma. And apart from this, you can also have cyclin D1 positivity. And even in cases which are going to be cyclin D1 negative, sometimes you can have a SOX11 positivity. So cyclin D1, SOX11, CD5 positivity along with CD23 negativity is the classical immunophenotype for a mantle cell lymphoma. Okay, so in 1114, usually this 14 location is there, right? So all of these B-cell lymphomas, if you see, it is somewhat going to involve the 14th chromosome. So in the 14th chromosome, you are going to have the heavy chain of the immunoglobulin. So IgH we call it as. So that is the locus. The locus for IgH is going to be present on the chromosome 14. So every other chromosome, some other chromosome is going to form a translocation with this chromosome 14, and that is going to cause the upregulation of the cell proliferation and survival in these B-cell lymphomas. So in this case, the chromosome 11 was the site in which the cyclin D1 was present. So cyclin D was a cell cycle regulator, right? It is a proto-oncogene helping in progression of the cell cycle. So when the cyclin D1 is translocated with this IgH, it is going to cause the upregulation of the cyclin D1 in these B cells, resulting in uncontrolled proliferation of the B cells. Then moving on to follicular lymphoma. So this follicular lymphoma, I mentioned, it is going to arise from the germinal B center. So germinal B center, and here again the middle age groups, the same as the mantle cell lymphoma, only the age group will be there. They are also present with multiple lymph nodes here, and the genetics involved here is translocation 14 and 18. So 14-18 translocation is for follicular lymphoma. And prognostically, if you see, the follicular lymphomas are going to be very indolent. So they are not very aggressive, they are quite indolent. So they have a good prognosis, right? So microscopically, if you see, again, this is going to be a small cell lymphoma. So follicular lymphomas and then SLLs, where both of these are small cell lymphomas. So the type of cells, lymphoma cells are going to be quite small. So microscopically, so they form a differential diagnosis for each other. So microscopically, if you see, what are those small cells here? These follicular lymphomas are going to be composed of centrocytes and centroblasts. So these are the normal cells which are present in the germinal centers. They have undergone this mutation, translocation, and they have become neoplastic now. So centrocytes are the so these centroblasts, centrocytes are just precursor cells to the mature lymphocytes. So these centrocytes are cleaved cells, meaning their nucleus is going, if this is the small lymphocyte, if you see here, it is going to have a very scant cytoplasm with a very hyperchromatic kind of a nucleus. This is the small lymphocyte. While if you see a centrocyte, it is going to have a cleaved kind of a nucleus like this. So this is the centrocyte. So since it is going to have a cleave, it is also called as the buttock cell. So buttock cell, where else did we see? Yes, it was seen in the microgranular variant of APML. So microgranular variant of APML and the follicular lymphoma centrocytes are going to have buttock cells. So centroblasts are the most immature cells here. So these cells are again have a classical morphology. If this is the cell, there is a nucleus. So at the periphery of the nuclear membrane, you are going to see multiple prominent nucleoli. So multiple prominent nucleoli arranged at the periphery of the nuclear membrane is going to be the classical morphology of the centroblasts. So this in a lymph node, if you see in a follicular lymphoma, the architecture of the lymph node is going to be effaced by diffuse sheets of this centrocytes and centroblasts. So based on the proportion of the centrocytes and centroblasts, they further grade this lymphoma. So we are not going to do that much detail. So in bone marrow biopsy, there is a classical thing for follicular lymphoma again. So paratrabecular location. So paratrabecular lymphoid aggregates. So this paratrabecular location is quite characteristic again for follicular lymphoma. So in the bone marrow, if you see, you are going to have multiple bony trabeculae like this, and then in between you are going to see the bone marrow hematopoietic cells. So in this, there is bone marrow. If you see a cluster aggregates of this lymphoid aggregates and near this trabeculae, this is called as paratrabecular lymphoid aggregates, you will have to suspect a follicular lymphoma if characteristic presentation is there. So coming to the immunophenotype of follicular lymphoma, being a B-cell lymphoma, it is going to be positive for CD19, CD20, PAX5. So all of these B-cell lymphomas we discuss are going to be positive for CD19, 20 and PAX5 here. Apart from that, being a follicular germinal center lymphoma, it is going to be positive for CD10, BCL6. Okay, so BCL6 and CD10 are germinal center markers. Then this there is something called as BCL2, which is going to be positive. So BCL2 positive is kind of very specific for follicular lymphoma, not necessarily specific, but as such it is going to be kind of specific. Okay, so why? Because in this there is going to be overexpression because of this translocation 1418, there is going to be overexpression of the BCL2. So BCL2 is an anti-apoptotic protein. So anti-apoptotic protein in the sense the cells are not going to die. So instead of continuous proliferation, it is more of decreased in the death of the cells. So that is going to result in the lymphoma. So BCL2 overexpression is going to be seen in two lymphomas here again. Firstly, it is follicular lymphoma. It is because of the translocation directly. And then we also have it in small cell lymphoma. But in small cell lymphoma, CLL, right? CLL small cell lymphoma, there it was because of the deletion 13q. So deletion 13q led to the loss of microRNA 15 and 16. So those microRNA 15 and 16, when it is lost, it is going to upregulate the BCL2 expression. So these two, like overexpression of BCL2, we are going to see in small cell lymphomas and follicular lymphomas. Then this follicular lymphoma, I told it is a very indolent kind of a lymphoma, right? But it can transform into a diffuse large B-cell lymphoma. So diffuse large B-cell is a lymphoma is going to be an aggressive kind of lymphoma. So many of the lymphomas can eventually turn into DLBCL. So this follicular lymphoma can turn into DLBCL here.